All right, so this is the remainder of the pain lecture that we talked about yesterday. So we had kind of ended where we were talking about narcotics, non-opioids, and adjuvant medications for pain. Let's talk a little bit about a PCA, or a patient-controlled analgesia. So this is going to allow the patient to self-administer their medication with minimal risk of overdose and some of those complications or side effects that we talked about with narcotics. Usually patients who get PCAs are severe surgeries, maybe cancer pains, traumatic injuries, where they're needing frequent IV narcotics and that the nurse just really can't keep up with administering it. It's not realistic, I think, for a nurse to be in the room every 30 to 60 minutes giving IV pain medication. And furthermore, your patient's pain levels aren't well controlled that way. So with a PCA, it allows the patient to get more consistent pain control, and it also allows them to be responsible for it. So if the patient is awake, they're having pain, they can hit their PCA button and it can give them a little bit of a medication or a little bit of a bolus dose. And then obviously if the patient is comfortable and they're sleeping, they're not awake to hit the button. So it really makes sense. Adverse effects are still the same things that we look at in anybody who gets IV narcotics or oral narcotics. Altered level of consciousness that's depressed, respiratory depression, constipation, urinary retention. In some cases, yes, low blood pressure. With PCAs, like we said, these patients are going to get a hand-controlled button that they're going to have pinned to their gown. And just to remember that with a PCA, or a patient-controlled analgesia, the patient is the only one that should be hitting the button. It should not be the family, and it really shouldn't be the nurse. It should be the patient. That's why it's patient-controlled. And the thought is, again, if it's patient-controlled, if the patient's comfortable in sleeping, the risk of overdose is low because they're not going to be awake to hitting it. Now, if the patient is sleeping and somebody else is hitting it, the risks for overdose is higher, obviously. So there's a short video under the Potter and Perry student resources that actually does show how two nurses have to be present when they're starting a PCA or actually changing the medication in a PCA. It's just another safety check, right? They still do the 5 to 6 rites of medication administration, but they're also just getting another layer of security. Anytime the medication bag is changed in a PCA, especially if there's a little bit of a waste in it, 2 nurses have to also be present and document it. All right, so some of our pain therapies that are topical. So topical analgesics, these are creams that can actually be an NSAID, as an antisteroidal, or an EMLA cream that is like lidocaine based. And so they're analgesics or topical anesthetics. And they can be creams, ointments, or patches. So a lot of times you might see a lidocaine or EMLA cream applied before circumcision, or maybe before an IV in a pediatric patient, or maybe before a Huber needle that's attached in somebody or inserted in a patient that has a portacath for chemotherapy. Sometimes maybe the NSAID creams they might use in like a patient who has arthritic pain in their joints. Okay? So it's a topical analgesic anesthetic that has numbing properties to it. Some other local anesthesia that we think about, it might be actually inserted with a subcutaneous needle. So there's going to be local infiltration of an anesthetic medication, most commonly lidocaine, and we can see it in 1% or 2%, and it's going to induce loss of sensation to that specific body region. So we can either have local or regional anesthesia. And sometimes with the local anesthesia, and like these pictures kind of represent, just around that localized area of tissue, are we going to numb it? And so we might do it for suturing. We might do it if somebody is actually getting an epidural. They might actually numb the area around it before we actually put in the epidural needle. Novocaine, in patients who are getting like oral surgery or dental care. And then there's also something, known as more of a regional. So you've heard of specific legs or arms like regional blocks. So it's a little bit more widespread than just the local area. It's more regional. It's more affiliated to a specific extremity. Some other types of anesthetic infusions that are local is called a perineural local anesthetic, and it's referred to as an on-cue pain ball. These are typically inserted by surgeons during surgery around the site of injury or that they've operated on. And the actual strings that come out of the on-cue pain ball are going to come out through the incision. What's in the medication is similar to like a lidocaine. It's a numbing agent. It's actually inserted kind of around the nerves that are around the area that has been operated on. This on-cue pain ball will stay in for about 72 hours. Nurses can pull it. It's not really sutured. It's more taped in place. And then the patient actually will carry this on-cue pain ball in like a little satchel. Okay. So it works over 72 hours. When the on-cue pain ball is filled in pharmacy, it actually has like a volumetric pump. It's not done by batteries or electric. It's just done by consistent pressure that gives a little bit of the medication around the area over 72 hours. So again, the purpose of it is to help with pain control, but also maybe to lessen the amount of IV or oral pain medications we give these patients after surgery. So some of the things to consider, right? Obviously, nurses can pull them after 72 hours, but we're also going to look around the insertion site to see if there's drainage or any type of infection. All right. So epidural analgesic. Okay, so sometimes people refer to it as epidural, spinal. This is considered a regional anesthetic, but it's more widespread, obviously, than local. And so we're going to see this analgesic administered in the epidural space of the spinal cord. And so typically, where the epidural is administered, the medication, below that level of region, below that level of application, the patient is going to have complete, lack of feeling, sensation. I think motor just depends on the purpose of the epidural, but definitely they shouldn't have a whole lot of sensation. Okay, so obviously patients come in for vaginal births, C-sections. Some of our patients who can't receive general anesthesia, they can't be put to sleep because maybe they're allergic to general anesthesia. They have a condition known as malignant hyperthermia. They have maybe some respiratory complications, so giving them general anesthesia and actually putting a breathing tube in and putting them on the ventilator temporarily is not really a good idea because we worry about more complications after surgery. So sometimes, again, other times we might see a continuous epidural in a patient who has such severe chest pain from a thoracic surgery or severe abdominal pain, and a PCA or IV narcotics is not working. So these patients will actually have a continuous epidural infusion for a while to get good, adequate pain control. So it can be intermittent, like with a vaginal birth, or it can be continuously after a severe, really acute surgery. That's really complicated. So obviously a CRNA or an anesthesiologist is going to insert this epidural and apply the medication. So, obviously working in the OR and the ICU, this is where we're going to be managing patients or even labor and delivery who are receiving intermittent or a continuous epidural. So it's a pretty specialized competency that we have to be aware of how to manage a patient who's getting an epidural. But we have to be also aware of the complications of an epidural. So if we have a regional block and we have no or minimal sensation below the level of application, we have to worry about injury to our patients. If they can't feel things, we have to make sure that these patients are safe and they're remaining injury-free. Obviously, this is in the epidural space, so we do worry about infection, we worry about bleeding, and we actually worry about cerebral spinal fluid leaking out of the epidural space. Sometimes abscesses can actually form from an epidural around the spinal cord, and it can lead to compression, so it can lead to some spinal cord injuries. Again, very rare complications, but things that we need to be monitoring for. So as the nurses who are taking care of these patients who are getting epidurals, we need to be monitoring the site. Is it dry? Is it intact? What's the date and time on the dressing? And is the area around it red? What's the drainage look like, hopefully, if there is none? This is kind of the position that some of our patients, if they are able to sit up, and it just kind of opens up the canal and the vertebrae a little bit so we can actually get the catheter into the epidural space. A lot of times when they are actually putting the epidural in, they'll have to do a wire first, or like a needle, and they'll have to put the catheter over this needle or this guide wire for adequate placement. So like we said, so some of the things that we worry about with any type of anesthesia is obviously emotional support. Sometimes it can be a little scary, frustrating for patients who have never had local or regional anesthesia. So we have to ease our patients' fear, comfort, use therapeutic communication. Like we said, our patients who have had local or more of a regional anesthetic where they have loss of sensation to that area or that extremity, we need to make sure that not only are we making sure these patients are safe, we're also monitoring their neurovascular status and their motor function. So we're constantly monitoring for their sensation and their return of full motor function. We talked a little bit about the complications from an epidural. And so we're doing a lot of education as well for our patients who are receiving continuous epidurals. Again, just like with anything else, with IV narcotics that we're giving intermittently or a PCA, we want to make sure our patients' pain control are being met, that their pain is adequately treated, that they're at their goal where we want them to be or they want to be, somewhere around a 2, 3. Are they able to function in the care? Anytime a patient has an epidural or a PCA, you have to be very concerned about giving them any additional pain medication. So most often, before we would consider giving them any type of other narcotics, we'd have to check with the surgeon or the anesthesiologist before we give these patients anything. All right, so some of the 3 terms you're probably familiar with. The term physical dependence. So this typically means that after usually about a day or 2 of patients who have had surgery, a trauma, any type of pain, who are on a narcotic, an opioid, these patients, if they're on the medication around the clock for a day or 2, everybody is going to develop a physical dependence. Okay? It doesn't mean these patients are addicted. The words are not used interchangeably. It's just a physiological response from continued use to this medication for appropriate reasons. Good, adequate pain control for healing and recovery. So we're going to see these patients have a withdrawal syndrome if the medication that they've been getting for the past couple of days is abruptly stopped or there's a rapid dose reduction. So what we need to make sure we're doing with our patients who are getting pain medications around the clock for a day or 2 is gradually wean them off the medications. So whether we space the dosages out a little farther or every day we decrease how much they're getting at a time, they need to make sure that they're slowly weaning themselves off, or we are weaning them off and educating them about it, because we know that it's common for patients to become physically dependent because it's a normal physiological process. It's nothing that they are doing consciously. It's just the way it is. Now with addiction, again, it's not the same thing as physical dependence. With addiction, it's more of a neurobiological, genetic, psychological factors that influences a person really becoming addicted. Only about 5% of all patients who come into the hospital for surgeries or traumas truly can become addicted. So the chances of it are very rare, but you're going to see your patients where they really have some preconceived notions about becoming addicted to taking pain medication for the appropriate reasons. And so we have to educate and reassure that just because you have a little bit of a physical dependence is not the same thing as addiction. Okay, so we have to educate them on their misconceptions. And then drug tolerance is the state of adaptation in which exposure to a drug induces changes that result in a diminutive of one or more effects of the drug over time. So they become tolerant of the effects of the drug. It's not working as much over time. And a lot of our narcotics, such as morphine, does not have a cap on it. It doesn't have a ceiling, which means that they're going to continue to get escalating doses, and over time they're going to build a tolerance to the drug where it's not going to work anymore at lower doses. And so you're going to have to continue to go higher in order to keep their pain, well controlled. And so we're going to see this in patients maybe who have cancer pains, terminal illnesses, who we're giving them, longer acting, long-term narcotics. So these patients, if there's a drug tolerance, if we are truly medicating these patients for a cancer or a terminal illness, sometimes we need to realize, yes, we will be going up on escalating doses, but then sometimes if it's not working anymore, we will have to rotate the drug to another type of narcotic, which is not uncommon in hospice palliative care situations. All right, so some other things to consider when we're managing pain is, like you said, effective communication, adequate education, early education. Our patients must trust that we believe their reports of pain. It's subjective, right? We have to listen empathetically, compassionately. We're not judging them. We're not giving them a sigh or giving them the eye if they are asking for something for pain, telling you they're in pain. So they need to know that we are committed to helping them and seeing this through to make sure that their pain is relieved. Okay. So we talked about a little bit of the difference between the three terms of physical tolerance, physical dependence, and addiction. That dependence and addiction is not the same thing. And that tolerance, a lot of our patients, again, who have cancer, long-term illnesses, are concerned that their pain will not be managed because they're going to develop a tolerance. So we need to reassure them that there are a lot of medications out there, a lot of different medications that can work together to relieve their pain, and that we'll do what we have to do to make sure that they're comfortable. So a lot of times we said reducing barriers to pain management. Again, fear of addiction. And we might see this in all patients, but I think maybe a little the older population, maybe patients who come from a different culture, who have different beliefs in illness and health, that might be an issue. I think fear of tolerance. I think a lot of your patients maybe understand the difference between addiction and tolerance, the difference between addiction and dependence. But sometimes they will say to you, I don't want to take this medication because I'm afraid I'm going to become dependent. Or they even might say addicted. So those are some barriers to pain management. They won't want to receive adequate pain medication because they're afraid, that they're going to become an addict or they're even going to become physically dependent. So we talked a little bit about the fear of tolerance and that their pain not being controlled. Side effects, and we've talked about those of narcotics and even the other side effects of the non-opioids. And so a lot of them can be transient, and if they can wait a day or two, they might resolve on their own. Some patients want to be a good patient. They want to be compliant. They don't want to create a lot of waves. They don't want to complain. And so they might not call out a lot, or when you ask them if they're in pain, they may kind of blunt to the extent of what they're feeling because they don't want to be a bad patient. Again, this might be cultural. It might be generational. Patients can be stoic. You can see some other signs and symptoms that these patients are in pain, but they're very stoic. They're just not very emotional about it. So again, we have to make sure that if a patient is telling us that they're an 8 or 9, and even though they appear very stoic, just because they're not having facial expression changes, behavioral changes, blood pressure changes, doesn't necessarily mean that they're not having pain. So in the restorative and rehabilitation phase, we know there's a lot of pain management clinics for patients who have chronic pain, spinal cord injuries, degenerative diseases, cancers. And we also have palliative care, that's a specialty that we're seeing in the pain clinics. We're also seeing it in hospice agencies. And there's even palliative care specialties that we see as an outpatient that are coming into the hospital that are managing all patients, not just the ones that are terminally ill, because pain control at all levels is appropriate, right? We want everybody to have an enhanced quality of life. And I think what they find is if patients our needs are met from a holistic perspective, if they're comfortable, they're just going to do better. Their outcomes are being improved. And in the long run, it's going to save us money. All right, so some additional safety guides to kind of review just in what we talked about is, with patients who have PCAs, they are the only ones that need to be pushing that button. Patient's family, friend, and really even the nurse shouldn't be pushing it. It's for the patient alone. That's why it's called a patient-controlled analgesic. We need to monitor our patients who are getting any type of narcotic for oversedation and respiratory depression, breathing 6 times a minute, shallow respirations, their oxygen saturations have dropped. And typically these patients, obviously, we're going to turn off the medication, and they're probably going to receive a narcotic antagonist like Narcan or naloxone, okay, to kind of temporarily block the effects of the medication. Again, we talked about the possible side effects of opioids or narcotics.